as everybody's finding their seats, just want to say thank you for getting out in the heat tonight to come and hear about cardiovascular disease from two of my favorite cardiologists. I'm Dr. Ryan Parker. I'm an ER doctor by training, so I get to work with these guys quite a lot with my ER patients, but I'm very excited to hear their talk tonight, as I know you guys are. So just as an introduction to give you a little bit of background on these guys, Dr. Patrick Henderson is going to be speaking first. So he spent a lot of time in Tulsa getting part of his training here, but started off his experience in Iowa and then moved to Colorado to do his medical school. Did his internal medicine residency training at OSU just down the road, and then did his fellowship here in Tulsa as well with cardiology. So we were happy to snag him and keep him here in Tulsa. Most of you, I think a few of you in the audience may see Dr. Henderson as a cardiologist or some of his patients. You'll notice my favorite thing about Patrick is his bow tie, and it's always fun to see which bow tie he's going to have. But some of you may not know that he also was a college athlete and was in the World Series for baseball. So you'll have to ask him about that. And he's an Eagle Scout, which means that he's, upstanding citizen. So. Dr. Venkatesh Ravi is another one of our cardiologists that's going to be speaking tonight. He did his initial medical training in India and moved here to Chicago to pursue cardiology. He did his fellowship at Rush and then did an electrophysiology fellowship and has a ton of skill sets as far as ablations and putting in pacemakers and working with those complex arrhythmias. However, he has some hobbies too, likes to ride motorcycles, and is an avid video game player. So that probably helps him with some of the electrophysiology pieces. But again, look forward to hearing them talk. We'll have some time for questions afterwards, but if you'll welcome these guys, Dr. Ravi and Dr. Henderson.
All right. Thanks everybody for coming. It's good to see a lot of faces I recognize in the crowd here. So I appreciate everybody for coming and their time coming out tonight to hear about this. I was actually given the topic of cardiology, which is 7 years for some of us and 6 for me to learn. So I tried to narrow it down a little bit into cardiovascular diseases, and then this is kind of the outline of the things that I was going to go through or kind of talk about. Really kind of focus on some of the prevalence of cardiovascular disease to understand, how prevalent it is across the U.S. and especially kind of in Oklahoma, which will be a unique graph that I'll show in a little bit. Some of the risk factors that are associated with cardiovascular disease that makes it so prevalent between the 5 kind of traditional risk factors. Talk through those and a little bit about each one of them so people can kind of understand why it's so prevalent. And then some of the things I was going to focus on in the last half was about some of the screening tests we offer here at St. Francis to kind of look at the different risk factors or kind of help risk stratify yourself in certain situations. And then the last thing I was going to talk about, especially with our AFib second half of this, was some of the home ECG monitoring or EKG monitoring devices you may have seen on the TV or people have between different monitors and go through those a little bit. So about prevalence of cardiovascular disease, more people die of heart disease than anything else in the U.S. combined. You could take all of the deaths from accidents, cancers, suicides, anything, put it together, and it doesn't pales in comparison to cardiovascular disease. There's some amazing statistics about somebody dying every 30 seconds from cardiovascular disease, or somebody has a heart attack every 40 seconds regarding cardiovascular disease or MIs or heart attacks. And, up to 20% of the people that die from heart disease are under the age of 65. So this is not necessarily just a 65 and older condition, but certainly something that happens across the ages. This is a slide that you'll see quite a bit. It's put on by the CDC that's presented a lot at different cardiology conferences. And this is from 2018 to 2020. And it's kind of interesting because if you were to go back, you could set it from like 1990 and then just watch, and this pattern stays pretty consistent across the years. And like we talked about, cardiovascular disease is extremely prevalent in the United States, and arguably, if you had to point out the epicenter of this, the most darkest red is right where we are here in Oklahoma. And, in a lot of categories, without Mississippi or Alabama, we would be pretty far down there. They can't keep us off the bottom in some statistics. But extremely prevalent, and they have this exact same graph for all of the risk factors that we're going to kind of go through. And to be honest, they look about the exact same as this because a lot of the risk factors are associated with cardiovascular disease. So what are some of these risk factors? There's really 5 traditional risk factors related to cardiovascular disease that we speak of in generality from a cardiology standpoint. Hypertension is one of them, or high blood pressure. This is the exact same graph with the prevalence of hypertension in people over the age 18, and you can see that graph looks rather similar, as obviously this is one of the risk factors for heart disease. A statistic that was kind of surprising to me, over half or nearly half of the adults in the U.S. have high blood pressure, but only about a quarter of those, or 24% of those, actually have their blood pressure under control. And there's a statistic that's out there talking about half of the population has high blood pressure. Of those half that have it, only half of them are actually on a medicine. Of the half that are on a medicine, half of them aren't on enough medicines, and that's where you get the 24% that actually are on, have their blood pressure under control. But this is a very prevalent thing that you see in one of the biggest risk factors, and somewhat asymptomatic. The same with cholesterol, or dyslipidemia is the second risk factor, and this is high cholesterol. 2 in 5 adults have an elevated cholesterol level, and this is one of the few things in medicine that has what we call a linear relationship, where the higher your cholesterol is, the higher your risk of heart disease is. And the lower your cholesterol is, the lower your risk of heart disease is. There's some graphs where they kind of have a curvilinear or an exponential growth, where at a certain point your risk goes really high. This is something that's very linear for us, that says if you have high cholesterol, your risk of heart disease is dramatically higher. There's usually not a lot of signs or symptoms associated with this. You have to get a lab or a screening lab, which most people get done to really find out what your cholesterol is. And really this is comprised of some genetics you may get, diet, exercise, and then the treatment for it falls a lot on medications. When we talk about exercise from a cardiac standpoint, I think the American Heart Association kind of recommends 150 minutes over a week, in 7 days of activity with your heart rate up in a range. So you spread that out across 5-6 days, it comes down to about 30 minutes of activity most days of the week. And then, diet. People like to ask me quite a bit, what do I think, or what diet should I do? What do I think about diets? And my diet spiel is pretty easy. People know what they should and should not be eating. It kind of boils down to that. I had people like to adhere to a certain diet, but a lot of times there's loopholes in diets. And one of my best friends in college did the Atkins diet, which is now the keto diet. And I have a patient that does keto diet. He eats ribeyes about 8 nights a week. He's lost all sorts of weight, but I think most people would agree that's not the correct diet to be on. And then one of my best friends here doesn't like when I call him a vegan because he owns leather shoes, but for all practical purposes, he is a whole plant-based vegetarian. But when he eats potato chips and Oreos, those are technically vegan, and mac and cheese 6 days a week is vegetarian. So you could be a vegetarian, you could be a vegan, and still not have the appropriate diet. Everybody knows what they should and should not be eating. More vegetables, fruits, fresh items, lean proteins that people should eat. What you should be doing, staying out of the middle of the grocery store, staying away from processed foods. Like I said, most people know that. And, the one thing I tell everybody is to be very realistic on what you want to do. Anybody can do anything for a week or a month, but you need to make a lifestyle change to actually change the future in things. And so, whatever diet you kind of pick, you need to actually stick to or do something that you can do. And if that's not eating meat, great, but for a lot of people, that's not a real thing. So again, you just need to be able to maintain what you can do, and we can all do, I say, a little better in our diet, activities, exercise. Diabetes is another big one. That's kind of the third big traditional risk factor. And this is something that, is arguably an equivalent to coronary disease because it's so prevalent and tied so closely to that. And diabetes has a slew of complications themselves between strokes, heart disease, nerve disease, foot disease, kidney, eye disease. And, it's kind of interesting to see about 11% of the population has diabetes. And about 25% of them are undiagnosed. They don't even know they have it. And then in terms of pre-diabetes, there's a rather significant population over the age of 65 that is either diabetic or pre-diabetic. So that's why you get checked quite frequently in terms of screening tests or blood tests once a year. Every 3 months, they watch A1Cs for diabetics because this is a huge risk factor for cardiovascular disease. Nicotine is kind of the fourth traditional risk factor. I don't really belabor this point too much. Most people know nicotine is bad. From a cardiovascular standpoint, that's all nicotine, not just cigarettes. But, this remains one of the largest preventable causes of morbidity and mortality in the United States. And, I think the numbers are getting better over the years, but it's still one of the traditional risk factors. And when people kind of come to me and say, how did this happen? And I say, high blood pressure, high cholesterol, diabetes, nicotine, and family history. Well, you can't pick your family, but you can control your blood pressure, control your diabetes, control your cholesterol, and you can quit nicotine. But I know that's, difficult and easier said than done. And the last one is family history in terms of traditional risk factors. We kind of define that as a first-degree relative with an event or an intervention, a stent, a surgery in men under the age of 50, 55, maybe 60, women 55 to 65. Aunt Edna, who was 95 and had a heart attack in 1920 that was a different era, a different time than where we stand now. So your great-great-grandfather that had a heart attack doesn't directly affect compared to all my brothers had heart attacks in their 50s and my dad died in his 50s and you're 40, you need to have your head on a swivel and be watching for that pretty closely because you've got some family genetics coming your way. It can also involve some lipid stuff. High blood pressure can be family related, and there's other rare kind of genetic cardiovascular diseases that can come out as part of genetics. The one example I kind of give in terms of family history to people is I don't know if you remember the show The Biggest Loser, but that was where they had those morbidly obese people work on aggressive weight loss. And one of those trainers, I think Bob was his name, he had the red hair, had a big, huge heart attack. And that guy, unless he was a closet smoker, was the epitome of health in terms of diet, activity, exercise, and did that for a living, but had very difficult family genetics that he had a hard time overcoming. And, people may say, I have this fate with my family history, but the real goal would be to prevent that for a period of time. And if it's going to come, you'd want it to come when you're 60 rather than 40, and push that out by doing the right things rather than burning the candle at both ends with a family history and these risk factors. So, we kind of talk about the prevalence of cardiovascular disease, and that's why it's so prevalent are those 5 traditional risk factors. And so really there's some screening tests that the hospital offers, which I wanted to talk a little bit about that I'm not sure everybody knows about, and whether this is applicable to everybody, it may not be, but certainly a family member may be worthwhile to consider this, considering most people in here probably have some form of heart disease to look at. So they do offer screening tests, and that's, really the goal in a screening test is to, identify people that appear otherwise healthy or have very low risks for a condition to see, do they have a higher risk that may actually be at an increased risk, where they say, I try to do the right things, eat the right things, exercise, but I still have, a family history. Where did I kind of fall in that spectrum of genetics where, I think I'm healthy, but am I actually at an increased risk of a condition or disease? And then usually the goal in these screening tests is to adjust lifestyle modifications or try to adjust medications to prevent future issues once you kind of know about the condition. And really, screening tests, the one caveat I got to tell everybody is this is not for people who already have the condition. If you've got coronary disease, you don't necessarily need to be screened for it. You already have this. We know about that. Or if you've got significant risk factors, like you're a diabetic, hypertensive, smoker with high blood pressure, and you want to know, do I have an increased risk? Well, the answer is already yes. We know that. Doing more tests to prove that would not necessarily change our management or our recommendations to people. There are different ways that we kind of do screening through cardiology or cardiovascular disease. Imaging is one thing that we'll kind of talk about over the next few slides, and a lot of times that's adults over the age of 40, some will go down to 35. And usually, like I said, those people that think they're healthy are doing the right stuff, but may have a family history that they want to know, did I get more of mom's genes or dad's genes, in terms of where I kind of stand on that spectrum, before it hits me when I'm 50, 60 or something like that. We do blood work where you get your cholesterol panel checked once a year to look for lipids. There are inflammatory markers we can order kind of in the cardiovascular office to know, or cardiology office to know certain markers that may put you at higher risk. You check your blood sugars once a year to look for diabetes. You get your blood pressure checked at every office visit you go to, and most everybody in here has a blood pressure cuff because that's such a prevalent thing that we talked about. And there's other things like waist circumference, body mass index with your height to weight, and then sometimes there's some monitors that people will pick up, which I'll talk about at the end as a segue into AFib that people will kind of use as their own little screening test. So one of the screening tests we order, and then a lot of people have had one of these before, is sometimes a screening echocardiogram, and this is an ultrasound of the heart to look at the size, the strength, the function of the heart, and look at the different chambers of the heart for thickness, weakness, leaky valves, sticky valves, and then this is an ultrasound, so there's no risk, no radiation, no IVs. But really, the screening test that we offer is not a complete study. I think of it as if you took your car to the mechanic and he popped the hood and you said, how does my engine look? He'd say, there's your engine, there's your alternator, there's your brakes. All the parts are there. A full echo or a complete echo would be the 90-point inspection, that looks at all the valves, all the corners, all the features of it. But they do offer a limited screening echo here and, really tries to look at the size and the strength and the function. And this would be the left ventricle here, or the pump of the heart, the right ventricle, an aortic valve, a mitral valve, and the left atrium. So it looks at a lot of components of the heart all at once in motion. And then we use these quite often to look for different cardiac conditions or situations people may be in. This gives us a lot of non-invasive information. Another test we order is what's called an ankle brachial index, and this is a test where they check the blood pressures in your arms and then check the blood pressures in your legs. And to be honest, most of the time those should be equal. The numbers in the arm should be the same as the leg. If we found that the numbers in the legs were lower than the numbers in the arms, it would make me wonder if there was a blockage in the arteries of the legs, lowering the blood pressure in the ankles compared to the arms. And if that was the case, it would make me think, is there blockages in your legs? And that'd be an important risk factor to realize, because if you've got blockages down here, you could have blockages here or blockages elsewhere in the body. And especially for diabetics or people, that are at increased risk of foot wounds or infections, having good blood flow down to those feet is important. So knowing what the blood flow looks like is usually a pretty important feature, like I said, especially for diabetics or for general risk stratification, because again, if you have blockages down there, we'd expect it to be elsewhere. The other test we order, and there's a couple more ultrasounds that we do, and that's a screening test for abdominal aortic aneurysms, and that's enlargements of the blood vessel in the abdomen. There's a big blood vessel that comes off the heart called the aorta, and that blood vessel takes blood to your arms, to your brain, makes the corner, comes down, goes to your stomach, your liver, your colon, your intestine, goes to your kidneys, and then splits and goes down each leg. And right around the belly button, there's an area that likes to get enlarged, or can be aneurysmal, which is our term for enlargement. And it's usually associated with atherosclerotic vascular disease or cardiovascular disease is what causes that. And it's a good screening test that we offer to people. And there's a group called the U.S. Preventative Task Force that sets colonoscopy guidelines, mammogram guidelines, different screening tests for the general population, and they would actually recommend this ultrasound for any male between the ages of 65 and 75 that ever had one cigarette in their entire life. To look for this, because this would be an important thing to know, because if this ever ruptured or tore, it's a pretty bad situation if that's the case. And so finding that upstream, knowing about that, watching that, there are preventative measures we could do to try and eliminate that being a problem in the future. But that's another simple ultrasound that we offer as part of a screening exam. The last kind of ultrasound screening exam we offer is the carotid arteries, or the arteries in the neck. This is again an ultrasound with no risk, no radiation, no IVs, just pictures. And it's another marker to look at blood vessels going up to the brain, just kind of like looking at blood vessels going down to the legs. You can live without a toe, you can't really live without a brain, so sometimes, looking at these arteries going up to the brain is important because that's associated with stroke, if there was something significant blocked in there. And, anecdotally, we had a patient the other day that came in, and she got this because her family member had a cardiac event, and she was found to have a blockage. It was rather significant, ended up getting it fixed, but picked it up on a screening exam. So that's another marker of vascular disease. Again, if you have it here, do you have it here, or do you have it down there? And it's a simple ultrasound in terms of a screening, an important area going up to the brain. The last kind of screening test I was going to talk about is a calcium score. I was a little hesitant to put this in, but I think it's important. This is a non-invasive way to look at the arteries of the heart. This is what we call a calcium score, and it's going to look at calcium in the arteries to look for plaque. This is not the calcium that you eat, unless you're eating mac and cheese all day, then that is where this calcium comes from, but not from your calcium supplement or anything like that. This is plaque in the arteries, kind of like calcium in a pipe underneath your sink. And so they'll do a CAT scan, so it's it does involve some radiation, it's not an ultrasound, and they scan the heart looking for evidence of plaque or cholesterol that may be there. And it can kind of help assess a person's risk, or really kind of move the needle one way or another from, I'm a little lower risk, or this puts me in a little higher risk categories compared to where I thought I was. I use this quite a bit for people that come to me and they say, again, where do I stand? I'm 50 years old or I'm 40 years old. Do I have any plaque or cholesterol? I think I'm pretty healthy. And their calcium score comes back at 0. That makes them much lower risk as compared to somebody that has a calcium score of 30, 300, 3,000, would put them in a substantially higher risk. And then I also have a lot of people that come and say, I really don't want to take a cholesterol medicine or one of those statins, and there's a calculator that the American College of Cardiology gives us to calculate who kind of needs a statin and who doesn't without a heart attack or anything. And they may say they don't really need one based on that, but they have a strong family history. We'll sometimes do a calcium score again to move that needle. No, you probably don't, or yeah, you probably would benefit from this. So it can really kind of help direction of treatment or patient's lifestyle. It's sometimes motivating to them in terms of cleaning up diet, activity, exercise, once they know something's going on in the background that you may not see or feel. A couple of caveats with the calcium score. It cannot tell the severity of a blockage. So if this is 0% blocked and this is 50 and this is 90, the calcium score does not tell us how narrowed it is. It just simply tells us, is there any calcium in the arteries or plaque in the arteries? Hard plaque, calcified plaque. This is not a test for anybody with known blockages already. One of my ultimate pet peeves is at the home and garden show or at different places. They'll trap you, put you into scare you that you need to get this test and buy 8 of these from them. This is not the case, and I've had people come in and they'll say, did you know I have an abnormal calcium score? And I'll ask them to lift their shirt and they'll show me the scar where they had bypass surgery. And I'll say, yes, we knew you had blockages. You knew that. This test told me you have blockages. We already knew this. And they're like, oh, I didn't quite realize that. So this is not a test for people that already have blockages. So anybody that's had a stent, anybody that's had a heart attack or a blockage or a bypass surgery, this is not a score. This is for people that don't know if they have blockages or not. And in that token, you would not need multiple tests. So once we kind of see that you've got blockage, we don't need to check it every year because that number is going to just keep going up. Again, at that point, the recommendation is the same. And again, it's not really for high-risk individuals or people with significant risk factors. They teach us pretty early in medical school, don't ask questions you don't believe the answers to, or don't ask questions you already know the answer to. We don't order pregnancy tests on men because if they come back positive, I don't believe it, And if they come back negative, I already knew the answer. So if you come to me as a 75-year-old with diabetes, high blood pressure, high cholesterol, and you smoked, and all your family members had heart attacks at 60, I don't need a calcium score. I already know the answer to that. It's going to be high. You need lifestyle modifications, control the blood pressures, cholesterol, diabetes, quit nicotine, and that's what the recommendation is. The calcium score would not really change my recommendation from that fashion. And this is what the test kind of looks like. So we do a scan, and it takes like an X-ray, and on X-rays, CAT scan is a series of X-rays, and calcium shows up on X-rays. That's why we take X-rays of bones and whatnot. And so you'd be looking for evidence of calcium or plaque in these arteries. And so this is the breastbone up here. This is the aorta, that big blood vessel that comes off. This is a pulmonary artery that goes to the lungs. And then this is the artery that goes down the front of the heart. This is the artery that goes down the side of the heart. And with the X-ray or the CAT scan, you can see somebody that has a lot of calcium, or how bright that is, going down the anterior, the LAD, or the artery going down the front of the heart, and then the artery going down the side of the heart. And so when you do these, this is what it kind of lights up with to show us. And again, as a screening test we offer in terms of knowing, is that there or is that not? And again, if you'd had bypass surgery or stents, that would show up on this scan, and we'd already know that's what it looks like, versus somebody that doesn't know they have coronary disease. And so really the last thing to kind of talk or mention about is kind of a segue into atrial fibrillation, of some of these home, what I call ECG monitoring that we do, or EKG monitoring. It's come a long way. It used to be that if you've got a problem, you had to come into the office to get an EKG, or go to the urgent care, or go to the ER to get an EKG done to look at the tracing of your heart for the rhythm. And there's really a couple of devices on the market now that are actually pretty decent without needing a medical degree to get one, or $10,000. We don't get paid to read these. I don't own stock in this. I don't get paid to advertise these, but they're actually pretty reasonable. The option on the left is about $80 at Best Buy, and you just walk in. It's not even behind glass. You just pick it up and walk out the door. And then the Apple Watch is a little more expensive version, but they actually do a pretty decent job at trying to pick up abnormal rhythms. And this is actually my EKG from last night off an Apple Watch. And so it's actually that pretty much straightforward, and comes up with a nice clean 30-second strip that may come out inconclusive, or it doesn't know, but usually we can kind of deduce, is there something real there or is there not? This is not for heart attacks. They're very clear about advertising that. This is a rhythm monitoring thing that people do at home to look for different rhythms, not plumbing problems like blockages in the arteries of the heart or things like that. This is an electrical thing that it monitors. And this is what an EKG may look like of AFib, where you have some irregularity to the beats, but it picks it up just the same that we can usually kind of deduce that or look at that if somebody were to bring that in. But these are just a couple of things that, in terms of screening things, or people will do at home kind of on their own to look at AFib or EKG monitoring. So with that, I'll pass this over to my partner, Dr. Ravi, to kind of go into atrial fibrillation. And then I think we have questions at the end. Mm-hmm.
Right. Thank you. All right. Thank you, Patrick. Thank you, Dr. Parker, and thank you, St. Francis, for organizing this town hall. And thank you, everyone, for taking your time off this evening to learn about atrial fibrillation. I can talk about this for hours, but we'll try to keep it short so we can have some time for questions. No relevant disclosures for this talk. All right, so I've kind of structured this so it's mostly like the questions I get in the office, and that's what we're going to go about. So the first question we get is, what is atrial fibrillation? So let's take a look at this cartoon here. Let's see. Laser pointer. All right. So if you can see this laser pointer, so on the left here, this cartoon, this is the 4 chambers of the heart. This is the right top chamber, the left top chamber, the right bottom chamber, and the left bottom chamber. Now, in a normal situation, the electrical signals come from the natural pacemaker called the sinus node, located here. They go through the electrical junction, and they reach the rest of the heart. That's what it's supposed to do, and that's how your heart is beating in a normal fashion. But when you're in atrial fibrillation, there is a disorganized, dysynchronous, abnormal rhythm coming from the top chamber, and that's what makes your heart beat rapid, irregular, and also in a desynchronous manner where it's no longer pumping as efficiently as it should. So what that makes it do is also develop the possibility of having blood clots, which increases your risk of stroke. So those are the three main things that the atrial fibrillation causes: fast heart rate, irregular heartbeat, and increases the risk of stroke. Just wanted to show you this from one of our procedures from a week ago. So this is an electrical map with our mapping catheters inside the heart. On the left here, again, this is what normal rhythm looks like. On top here, this is part of the EKG that Dr. Henderson was showing earlier. This is how it looks like when you're in the normal rhythm. This down here, I hope it's displaying okay there. Yeah, this down here, where you can see the sharp spikes, that's what normal electrical activity is supposed to look like. But when you can see, this is what happens when someone's in atrial fibrillation. This is what's going on inside their heart. Dysynchronous, continuous electrical activity where the cells, they're not, really communicating with each other. They're just beating in a haphazard manner, chaotic background. And that's what's causing those three things we talked about: the irregular heart rate, the fast heart rate, and the increase in the risk of stroke. Now, coming back to the next question, how common is it? What is the burden of atrial fibrillation? Unfortunately, it is getting more and more common. The burden's increasing as the population is getting older. The higher incidence is usually an older white male. That's the typical patient. And we've also been seeing that, in the previous data that is there, this is from CDC, in Medicare beneficiaries, that's people above 65 years of age, it's around 2.8% and around 8% in terms of prevalence data. So by 2030, it's expected that about 12 million people, that's about almost 3% of the American population, and this is the burden in the United States, not the world. So that's the prevalence of atrial fibrillation. And the impact of that is, increase in hospitalizations. It's about 450,000 hospitalizations per year, 150,000 deaths. 15% of the strokes are related to atrial fibrillation, and also a significant cost impact as well. And this is older data. This is data from 2012, 2007. Probably it's going to be much higher right now. This again is the chart, similar to what Dr. Henderson showed a few minutes ago. Again, focus on our eastern Oklahoma, Tulsa area here. Dark red means that there is a higher hospitalization rate from cardiac arrhythmias, especially atrial fibrillation, since it's the most common cardiac arrhythmia. And we can see here the cluster around the east Oklahoma side that we are in the higher incidence of hospitalizations. The more interesting one is we look down at Hawaii, and they have a very low incidence, so maybe something about the lifestyle there to emulate. This again is a chart, showing the age-standardized incidence rate of atrial fibrillation across the world. Again, unfortunately, United States among the highest incidence rates. Now, the South American, African, Asian data, I'm not sure how reliable it would be, since we're not sure if the detection rates are as good there, but we can compare with Japan and other emerging economies, and we can see that in Europe as well, some of the Mediterranean areas and Japan, the incidence is much lower. So again, something to look at, that we can follow some of the lifestyle choices there, and that could be some way we can cut down on atrial fibrillation here as well. All right, so next question I get, common thing, what causes it? Why do I have this atrial fibrillation? There are a lot of causes. The list is pretty long, but try to squeeze them all into one slide here. Comorbidities, like Dr. Henderson was talking about, one of the most common ones: hypertension, heart failure, diabetes, blockages in the blood vessels of the heart, any valvular abnormalities. Think of atrial fibrillation more as a result of something that's going wrong with the heart more often than the cause of it. So it's more of a warning that's telling us that something needs to change, and that's what this is highlighting, so the incidence among the high comorbidities. The next thing is age. As we get older, the incidence of atrial fibrillation goes up. You're at a higher risk. And one of the things to a common association is as we are older, the comorbidities increase as well. So that makes sense that age is a significant risk factor. And just like the rest of the body, the heart gets older as well, the electrical system gets older, and it has more unstable cells which trigger atrial fibrillation. Obesity is a trigger. The adipose tissue is a direct inflammatory component which can trigger atrial fibrillation by itself. Alcohol, another inflammatory cause. That's why there's a syndrome called holiday heart syndrome. Binge drinking of alcohol, big trigger for atrial fibrillation. Sleep apnea. This is something that we have seen as well. Untreated, undiagnosed sleep apnea is another big cause for atrial fibrillation. Lifestyle changes, they kind of tee up into the rest of the factors that we are seeing here as well, but diet, sleep, and exercise, these three are very important, and they are causes for atrial fibrillation if it's not appropriate. Pollution, probably not something we can control, but that's another big trigger. There are genetic causes because we are seeing in younger patients as well, some of them having atrial fibrillation. So sometimes if they have abnormal channels in the electrical system of the heart, that's a big trigger for atrial fibrillation. In the setting of a critical illness, somebody's in the hospital, they're septic, they're infected, that's a big trigger for atrial fibrillation. Most of the times when the critical illness resolves, the atrial fibrillation goes away, but sometimes that can cause an irreversible trigger. And something that we have seen with COVID as well and any viral infection, that the inflammation from these viral infections can trigger atrial fibrillation. Thyroid diseases, that's another trigger for atrial fibrillation. Cardiac surgery, people who have recent cardiac surgery, in the first 2-3 months with the inflammation in the heart, they have a higher risk of atrial fibrillation. Again, most of the times we hope that this resolves by itself, and after 3 months we monitor to see if they have recurrence of atrial fibrillation. There are also a lot of medications which cause it. Some of the common medications like diuretics that patients are on, pantoprazole or protonics, which causes electrolyte abnormalities, some medications which affect the heart. There are a lot of medications which can trigger it, so something to keep an eye on. Next thing going into is the risk factors and triggers. Think of this as if someone has atrial fibrillation, what is it that can make this worse? So diet. We do know that processed food, sugar, is a big trigger for atrial fibrillation. An interesting thing, and this is something that I didn't think of much before, is people eating fast or larger meal, that's a trigger for atrial fibrillation as well, because the nerves that control the stomach are also controlling the heart, the vagus nerve. And a fast eating or a large meal can stretch the stomach, and that triggers the nerve that controls the stomach, which can also trigger the nerve that controls the heart, leading to what we call as vagal stimulation, and sometimes that's a cause for atrial fibrillation. Sleep deprivation is a trigger, and diet, sleep, and exercise, all three are important. So the focus on the sleep. Some of these watches, these Apple watches can track the REM sleep as well. So as technology gets more efficient in monitoring these, we may get better in, looking more and focusing on these. Exercise, getting good amounts of exercise. Mild to moderate level of exercise is good. What we realized is too much exercise may not be good as well. People who go for marathons, long distance runners, due to their electrolyte abnormalities, they are at risk for atrial fibrillation. People who don't do any exercise, they are at risk for atrial fibrillation. So mild to moderate level of exercise, moderation, that's the key. Caffeine, that's another trigger. The usual target is around 100 milligrams per day. That translates to around 1 to 1.5 cup of coffee per day. Anything more than that usually starts to be a trigger again. Alcohol, as we talked previously, it's another big trigger. The usual limit is around 1 drink per day. I'm not encouraging you to go and drink alcohol now, but if you are, 1 drink is the usual limit. When you exceed that, the risk starts going up exponentially. The higher, the more the risk. Dehydration is another risk, and it's a common joke that probably 25% of us in this room are dehydrated at any given point. So that's a big trigger, so keep an eye on hydrating yourself well. Stress and anxiety, those are other triggers. Social and demographic factors, other triggers. Energy drinks or stimulants, triggers as well. Again, because they have caffeine component in them. What are the symptoms of atrial fibrillation? The interesting part is the most common symptom is fatigue. which makes it challenging and difficult because, as we get older, we think, oh, it's probably because I'm getting older, and that's why I don't pay a lot of attention to it. But if there's been a sudden change, you could do something a day before and you're no longer able to do it, something's not right. And that's probably that your heart is out of rhythm. And that's why fatigue is most common symptom of atrial fibrillation, because the heart is not pumping as efficiently as it should anymore. The other symptoms are being short of breath, palpitations, feeling like your heart is racing, feeling dizzy, in rare cases losing consciousness, or having chest discomfort as well. There are a lot of other symptoms sometimes. People can have atypical symptoms, but this is a common list of it. What are the types of atrial fibrillation? So this is think of atrial fibrillation more as a spectrum of a disease. So initially, it starts with paroxysmal episodes, which means your heart is going in and out of atrial fibrillation by itself. The usual cutoff we use is that it converts to the normal rhythm in less than 7 days, either by itself or using an intervention. The next part is persistent atrial fibrillation, which means your heart is staying in atrial fibrillation for more than 7 days and up to a year. This means that the disease status is progressing where your heart is now sustaining the atrial fibrillation. The electrical channels in the heart are starting to show changes. The next part is long-standing persistent. What that means is the atrial fibrillation now, you've been stuck in it for more than a year. What that affects is that the heart chambers have now started to enlarge. The electrical channels have modified significantly, that interventions to try to get someone back into normal rhythm, they are going to be less successful. So these types of atrial fibrillation also dictate what the success of that particular patient undergoing an intervention is going to be as well. Permanent, this term is a little vague, but this is a point where a doctor has said that any additional intervention is not likely to bring you back into the normal rhythm. And as technology advances, this always changes. So someone who was deemed permanent a few years ago, now with the changes in the technology, they may deem them that yes, there could be a possibility of doing additional intervention. So this varies based on whether the cardiologist or the EP physician has decided that the additional intervention, the risks of it outweigh any additional benefits at that point. So moving on to the management portion of it. So we've seen what atrial fibrillation can do, and now what is it that we can do to control it? There is a high risk of mortality and morbidity associated with it, but it doesn't mean that it's a time to fear. It's just a time to take control and make these changes. So there's 3 key things that we'll be focusing on, and we'll be going through all of these in detail. The first thing is the risk factor modification and monitoring. Just like I was talking about some of these while we were discussing the triggers, but we'll go over them again. The next thing is going to be the medical therapy, the important medications anyone who's diagnosed with atrial fibrillation needs to be on. And the third thing is the procedural interventions. What else can we do? And that's where we come in at St. Francis as well. So the first part, risk factor modification. With the diet, a good example of a diet is a Mediterranean diet, balanced diet. As Dr. Henderson was saying, trying Atkins diet, those vigorous diets, they're difficult to sustain. So whatever changes you make, these need to be sustained in a long-term fashion. Broad outlines, less processed food. That's a big trigger, a cause for a lot of problems beyond atrial fibrillation. Less sugar content, less red meat, more fruits and vegetables, more nuts, and as we talked previously, eating in smaller quantities and in a slower manner as well. Weight loss, a good target is 10%. It may be difficult to achieve, but any weight lost is a good risk factor modification. We do know from data that about 1 to 2 pounds of weight loss reduces your risk around 0.5 percentage point. So that's a good trigger. If 10% is too much, any weight loss also helps. Good sleep, that's a significant risk reduction. As we talked about, increasing the amount of exercise and just mobility. Sometimes it may be challenging to go out and exercise. I'm guilty of it as well. It's difficult with the lifestyle that we have to actually find time to have those exercise regimen. But just having more mobility, when we're watching TV, just doing some sit-ups, just trying some mobility and exercises, that's a significant risk reduction. Caffeine, as we talked about, 100 milligram per day is the cutoff for that. Alcohol, again, 1 drink per day and less than that, reducing anxiety and stress. And this is one of our studies we published on for the weight loss, and I just wanted to show that a reduction in weight loss reduces your risk of atrial fibrillation. So this graph, this red thing that's pointing, if it's to the left of the line, it favors that particular intervention. And we can see from the data here as well that a weight loss of more than 10% favors a significant reduction in risk of atrial fibrillation. The next thing is monitoring. Now, this is important too, as Dr. Henderson pointed out. There is the Cardia Mobile, there's the Apple Watches, there are a lot of smart watches and tools that are coming out. As technology evolves, these are going to get better, and it's going to become more and more simpler for people to use it and track their atrial fibrillation, see how well the changes they have made are actually paying off. This is challenging, it takes a lot of commitment, but it's important that, these are worth it because you are worth it, your health is worth it. There's an interesting story that Dr. Bunch talks about, he writes it in his books as well. Let's call this patient Joe. Patient Joe was diagnosed with atrial fibrillation. He did a lot of research on it. He saw the high mortality and some of the studies that was associated with it in the past. He thought, okay, my life is ending. He decided to just give up all the stressful lifestyle. He decided to go live in the woods, in a cabin in the woods. I mean, probably not a haunted cabin, but a good cabin in the woods. Interestingly, he was having a stress-free lifestyle there. He was getting good exercises. He had a good, air quality there, no pollution. He was eating healthy. And he realized after a few months that he hadn't had any episodes of atrial fibrillation. So, I'm not saying that we all need to go live in the cabin in the woods. But the bottom line is that these risk factor modification, these lifestyle optimizations, they work. Think of it like when you go to a dentist. You have a cavity, the dentist can fix the cavity. And that's what we try to do as well. We do procedures, we do medications. But they need to be accompanied by making changes in the lifestyle as well. Otherwise, the cavity is going to come back, the atrial fibrillation is going to be coming back as well. So now moving on to the medical therapy. So whenever you come into the hospital or you see any physician, you've been diagnosed with atrial fibrillation, these are what you'll be started on. The first thing is anticoagulation, which means blood thinners. Because as we talked about, atrial fibrillation increases the risk of stroke. And we use certain risk factor calculators. One of them, the popular one, is called CHADS-VASc. It's basically an abbreviation for having someone with congestive heart failure, high blood pressure, age, diabetes, having a history of stroke. These are just risk factors that we are looking at. The more the number of risk factors, the higher their risk of stroke. And usually if you have 2 or more risk factors, that's where the benefits of blood thinners outweigh any risks. And that's where we start recommending these blood thinners. There are these newer blood thinners called novel oral anticoagulants or direct oral anticoagulants, and you may have heard of these in the ads as well. One of the most common ones is apixaban or Eliquis. The next one is rivaroxaban or Xarelto. These are the commonly prescribed medications to reduce the risk of stroke, and the data shows that they're pretty effective. And in comparison to warfarin, which was an older blood thinner, the problem with the warfarin is, it was called rat poison in the past, but other than that, the problem with the warfarin is that it does work, but there's a difficulty in taking the medication. The levels fluctuate with it. The levels can rise up and down. It changes with the diet. We recommend, people eat green leafy vegetables, but with warfarin, the greens interact with it, driving the levels lower, and when you don't eat it, the levels go up. It creates a hassle. People require frequent blood work. They end up not having what we call as time in therapeutic range, which means 2 to 3 is a therapeutic range. And if the time is less than 70% of the time that you're staying in the normal therapeutic range with warfarin, then neither are you getting the benefit, and then you're exposing yourself to the higher risks of bleeding associated. So that's where these newer drugs came in, because the data showed that they were more safer than warfarin and more effective. But of course, since these are newer medications, they end up being way more expensive. and that's the problem with it. Dabigatran, Pradaxa, that's a medication which has been approved to go generic. So it's time, maybe in the next few years, these newer agents, the Eliquis and rivaroxaban, they'll go generic as well. So we'll have more options. But the guidelines currently, based on the risk-benefit profile, they do recommend these newer agents over warfarin. There are these alternative procedures where if someone cannot tolerate a blood thinner, let's say they're having major bleeding issues, they're having blood in stools, blood in urine, requiring hospitalizations, requiring blood transfusions, or they're having bleeding in their brain, they can't tolerate a blood thinner, then there are these procedures called left atrial appendage clips or exclusion devices. A common device or something you may have heard of is a Watchman device, which sits in a chamber, the left top chamber. There's a pouch called the left atrial appendage, which has the highest risk of forming the blood clot, and it seals it off, and that's how it reduces the risk. There are other procedures called amulet. There's an AtriClip, which requires a small surgical incision to insert the device. But these are alternative options. We don't have data as of now to suggest these as a choice. Those trials are undergoing right now. But right now, they're indicated if someone cannot tolerate a blood thinner due to significant bleeding risks. The next medication is going to be rate control. So you may have heard of these beta blockers, calcium channel blockers. These medications are designed to slow down your heart rate, so they solve the problem of your heart rate being too fast. Digoxin is one of the older medications. It doesn't drop the blood pressure, so in someone whose blood pressure is running really low, this medication becomes an option. The next class of medications, these are called antiarrhythmic drugs. These are more stronger medications designed to maintain normal rhythm. Unfortunately, they do have side effect profile as well. So that's where they come in. They have benefits, but they have risks associated with them. The first two classes of medications, the anticoagulants and the rate control, probably all of the patients would be on it when they're diagnosed with atrial fibrillation. Antiarrhythmic drugs, this is something, the EP physicians or the cardiology physicians, we have a detailed discussion with the patients about what are the risks and benefits of it, and then depending on their symptom profile, we go ahead with starting these medications. The first line among these antiarrhythmic drugs is something called flecainide or propafenone. These are the two commonly used medications. These two are some of the medications with the lowest amount of side effect profile overall. There was a recent trial called East AFNet trial. In the past, we used to think that these medications may not help prolong life. We knew that they could make people feel better, but we didn't know if they could help make people live longer. But there was a positive signal from one of the trials which showed that yes, using some of these drugs does help in prolonging life. And that was because majority of the patients were on these flecainide propafenone, which does have lower side effect profile compared to another medication you see on the bottom of the list, which is the amiodarone. The amiodarone is the strongest medication we have to control atrial fibrillation. It's pretty effective, but unfortunately, it does have a lot of side effect profile when someone stays on it long term, and that's what we are constantly monitoring for. So, if someone's on this medication every 6 months, every year, they are getting blood tests, monitoring their liver function, their thyroid function, we're monitoring their kidney function, their lung function. They need an annual check for their eyes. So those are things we are monitoring for. The other medications in the middle, Multac or dronedarone, it's a newer medication again, so it is expensive. But this is a medication which has some components of the amiodarone, but it doesn't have the toxicity profile associated with it. So it's not as effective, but it is more safer in terms of the long-term side effects. It does have some risks of causing abnormal or dangerous rhythms from the bottom chamber. So that's why whenever we start these medications, the dronedarone, the sotalol, or the dofetilide, there are electrical intervals that we are closely monitoring to make sure that that medication is safe for you. If your heart rate is less than 50 beats per minute, or if you're on certain medications which interact with these drugs, then the dronedarone, sotalol, and dofetilide are not safe. So whenever you see us, we are looking at a lot of factors. What is your heart function? Do you have blockages in the blood vessels of the heart? What are the other risk factors that you have? And depending on all of those, we make a decision on whether one of these drugs are appropriate for you. And once you're on these medication, we also frequently monitor with an EKG and blood work to make sure that it's continuing to remain safe for you. The goal of all these drugs is to maintain normal rhythm. If you are not maintaining normal rhythm, these drugs are no longer useful. There's no point in staying on them. You're just exposed to the side effect profile of it, and you're not getting the benefits. Bottom of the list, you see something called direct current cardioversion. That's essentially the electric shock where we are using it to resynchronize or reset the heart back to the normal rhythm. That's a common way, or it's the initial line. If someone's in atrial fibrillation, they're stuck in it for more than 24, 48 hours. We put these patches in the front and the back of the chest. It's not like in the movies where they use the paddles. It's more with the patches now. We give deep sedation to knock them out for a minute or two so you don't feel the discomfort. And that's when we deliver the electric shock, reset the heart back to normal. The problem with the cardioversion is it's effective in resetting the heart, but it doesn't prevent you from going back into atrial fibrillation. That's where these medications come in. And the next option, which is the catheter ablation, this is one of the advanced interventional procedures designed to reduce the risk of atrial fibrillation recurrence. So we do know from data that the catheter ablation improves the hospitalizations from atrial fibrillation, it improves the heart function, it significantly reduces the risk of atrial fibrillation. There is recent data that it may also improve mortality, which means people can live longer. And this is something we showed in our study a couple of years ago. There was a significant, and this is a pooled analysis of more than 20 studies that were published on this atrial fibrillation, comparing the catheter ablation with medical therapy. Again, if this diamond is to the left of the center line, it suggests that it favors the ablation, and we can see that there is a significant reduction in the risk of mortality as well, potentially with the atrial fibrillation. This is, as we get more data, we're going to find out more on whether the atrial fibrillation ablation prolongs life. In the past, the procedure was, it would take longer, was associated with higher risks, but with the advances in the technology, the procedural success rate as well as the complication rate has come down significantly, and that's where we are seeing the benefit come out, that it may actually help reduce mortality as well. Now, off note, one thing to remember is that with the current technology and the current understanding we have of atrial fibrillation, the ablation is not a complete cure for atrial fibrillation. Sometimes people come to us, they say, fix the heart. I mean, we try to do it, we try to do what we can, but it is not a 100% cure. The ablation has around 80% effectiveness in cutting down on the atrial fibrillation recurrence. It is the best tool we have in fighting the atrial fibrillation. And the success also depends on where in the disease process your atrial fibrillation is. Someone going in and out of atrial fibrillation, very symptomatic, those are the ones with the highest benefit from the ablation. Those are the ones who see the 80% reduction in the episodes. They do well. They could go for several years without having an episode of atrial fibrillation. Someone with long-standing persistent, which means they've been stuck in atrial fibrillation for more than a year, they are the ones who may have less success, sometimes in the 50s to the 60% in terms of the ablation in cutting down on their atrial fibrillation, because the heart chamber is already remodeled, and we are essentially fighting the heart and stopping it and going back into atrial fibrillation, but it may not stick, and that's one of the limitations with the current technology. Now, this is always evolving, so in future we may find out. Is that the timer for 6 o'clock? Oh. No, I thought I was exceeding the time. I can keep talking. And so let me know once it's 6 o'clock. All right, so there's different ways of doing the ablation. One of the more proven technologies that's been around for a long while is the radio frequency ablation. This is what you would have heard of as the heat energy. The next one is the cryoballoon, which is the cold energy. There is a lesser prevalent one technology called laser balloon ablation as well. And then there's a newer emerging technology called pulse field ablation. This looks promising, so in future, maybe in 5 to 10 years, this could take over, and we could see significantly improved safety and effectiveness. But right now, the main workhorse is the radio frequency ablation. And I just wanted to show you one of these pictures from a procedure that, this is just a procedure from last week. So if you can look at it, this is a picture of the electroanatomic map. This is actually what one of our screens looks like when we are doing the atrial fibrillation ablation. So just a quick thing before we go into this. This is an outpatient procedure done with general anesthesia. It's a minimally invasive procedure, which means we place IV tubes in the blood vessels in the groin, a couple of IV tubes on both sides. We advance electric catheters all the way to the heart, and then we cross over to the left top chamber, and this is what it looks like once we have crossed over to the left top chamber and created this electrical map. This is looking at your heart kind of from the left side, and this is looking at your heart from the back side of the heart. These tube-like structures that you're seeing come out of it, those are the lung veins called the pulmonary veins. They carry blood from the lung to the heart. They have abnormal electrical cells in them, which is subject to stretch sometimes, and it's more irritable than the rest of the heart, and it has a high risk of triggering atrial fibrillation. So our goal during the ablation is to electrically isolate these blood vessels here. This structure here is called the left atrial appendage. This is the area that has the highest chance of causing the blood clots and stroke risk. So when we are doing the Watchman device to seal up, this is the area that we are sealing up with the Watchman device. This is the ablation catheter. This is the catheter that's delivering the heat energy and burning the area of the heart. Each of these dots represents the burn lesion. They're about 2 to 3 millimeters wide. And this is what we are looking at. We're going point by point with precision, creating the line of block all around those blood vessels to electrically isolate them. This technology has advanced quite a lot over the last 15, 20 years. So right now when we do our ablations, we actually see the catheter in real time, and it shows us which way is our catheter pointing, how much force do we have on it, what is the energy we are delivering, what is the change to the tissue that it's causing, what are the risks. We know it before it can, if things can go wrong. That's how the safety and the effectiveness of the ablation has been significantly improved. This is another picture of the electrical map. This is looking at the heart from the back. This is one of our patients from a week ago. So this is what the left top chamber looks like. These tube-like structures, again, are the lung veins. These are the areas, as I said, they trigger the atrial fibrillation. Purple means that there's normal electrical activity. Red means that there's no electrical activity. Essentially, we don't want to see any electrical activity inside these lung veins because, we know that they are unstable electrical cells that could trigger the atrial fibrillation. So that's our goal for the ablation. We're creating this circle of isolation around the vein on both sides, and once we have electrically isolated it, this is how it looks. So red is electrically silent, and this, we confirm it both ways. We make sure that electrical signals are no longer able to get into this vein, nor are they able to come out of that vein. So think of it like we're building an electrical wall around those abnormal structures. This is someone who had atrial fibrillation for a longer time, and again, purple means that there's normal electrical activity. Red means that there's abnormal electrical activity, and things in the middle suggest that there is abnormal voltage or scar tissue in the heart. Someone's been in atrial fibrillation for a long time. This is what happens. The electrical cells are changing, so we now have to go beyond just isolating the lung veins. We also electrically isolate the back wall of the left top chamber, and that's how we try to reduce the risk of atrial fibrillation coming back. One of the reasons why you hear that people may require more than one ablation is that the heart tries to heal up. So if that happens, what can happen is that the area that we have electrical isolation in, it can start to leak electricity again. So that's what we try to go back in. If we ever go back for the second ablation, we try to find that spot precisely and burn that area again. These are more of the second-line resorts or second-line options. So someone's having atrial fibrillation, they've been stuck in it for several years, they've had an ablation attempt, it's been unsuccessful. That's where this approach comes in, where it's a two-step procedure, where one part of it is where we implant a pacemaker. The pacemaker doesn't help control the atrial fibrillation by itself, but if it's coupled with a simple ablation, so as I was saying, the atrial fibrillation is in the top chambers. All the electrical signals have to cross this narrow electrical junction to reach the rest of the heart. If we deliver a precise burn to this area, we can completely block the signals going from the top to the bottom. So even though you remain in atrial fibrillation here, the bottom chambers are purely controlled by the pacemaker. So that's what the option of pacemaker and AV node ablation involves. So it's a pace and ablate strategy. And the data does show that, compared to someone who's stuck in atrial fibrillation just being managed with medication, the pace and ablate strategy can help them, especially if their heart rates are uncontrolled. If their heart rates are running more than 90s to 110 beats per minute, constantly their heart is going to tire out and their heart function is going to get worse, and this is a strategy to help them. The hybrid AF ablation, this is again a more recent strategy that's been coming out for patients who have long-standing persistent atrial fibrillation, which means they've been stuck in it for more than a year. It's a two-stage ablation procedure. The first part of it is done by the surgeons. Again, it's not an open chest sternotomy procedure. They're making an incision below the breastbone here. They're putting tubes that go behind the heart, and then they're able to use precise catheters to burn on the back wall of the left top chamber. One additional advantage that gives the surgeons when they do the ablation from the outer side of the heart is their catheter is insulated on the back side. The food pipe is a structure that runs on the back wall of the left top chamber. When we are ablating from inside the heart, that's one thing we are constantly monitoring. We have a temperature probe to see if the temperature in the food pipe is going up, so that if that happens, we stop our ablation, we wait for the temperature to cool down so we don't cause any damage. But with the surgical ablation, since the catheter is insulated on the back wall, they're able to ablate more extensively with lesser risk of damage to the esophagus. Once they're done with their ablation, we then go back with the catheter-based approach from the groin, see the areas that they've not been able to reach, and then electrically isolate those lung veins. So this combined two-stage procedure adds an extra 10% to the overall success for these long-standing persistent atrial fibrillation patients. Now, the ablation does have risks. We talked about the success of it. We do need to know about the risks as well. There are rare risks of bleeding, infection, rare risks of injury to the lining of the heart or the structures that surround the heart. There's rare risks of stroke or heart attack or injury to the food pipe. These risks are usually 1% or lower. That's something we are being very careful at St. Francis as well, and we have had a complication rate. Don't want to jinx ourselves, but we have had a pretty good in terms of the complication rate to keep them down. Surgical AF ablation, this has fallen out of favor. It's a good thing to do if patients are going in for surgeries. If they're having a heart surgery, they're having a valve replacement, they already have atrial fibrillation, then it's a good thing to do at the time of the surgery. But doing a sternotomy procedure for atrial fibrillation alone, the data doesn't show anymore that it's a benefit, because you are exposed to significantly higher risks associated with the sternotomy procedure and opening up the heart. The catheter-based procedures have much lower risk and equal or even superior effectiveness in some cases. All right, so we're at the end of this now. So just summarizing, atrial fibrillation is pretty common. It's going up in burden, so it's important that we work on optimizing our lifestyle and keeping an eye on tracking our rhythm. There is medical therapy, so whenever you see your physician and you're diagnosed with atrial fibrillation, there's some medications that are going to start you on. There are these ablation procedures and other interventions that can be done to help you further. There are several ongoing studies as well. AI coming up is probably going to be an interesting tool. These smart watches coupled with closer monitoring could replace long-term blood thinner strategies as well. Instead of taking blood thinners all the time, there could be an option where people take blood thinners when they're diagnosed. Their watch lights up saying they have atrial fibrillation. They take it for 30 days and then they stop it. This works if somebody's having infrequent symptoms associated with it. Right now, we don't have any data to support that, but in future, there could be a lot of options going that way. Okay, all right. And finally, never give up.
It's a hand.
All right. Thank you. All right.
So we'll open up for questions, and I think that maybe I need to get off my 12-year-old's back about video games, because those pictures are really cool, and if you're good at it, then maybe I need to leave them alone. Anybody have any questions?
I had heard one of them, 2026 is what I had heard, maybe about generics on some of those.
Yeah, the Pradaxa.
At least some of them coming through, so it's coming, but not in the next year or the 6 months. We're not holding out for that, but yeah, it's coming.
I understand there's AFib and AFib with RVR. Can you explain the difference?
Yeah, RVR means rapid ventricular response, which means your heart rate is more than 110 beats per minute. So when you're in atrial fibrillation, your heart rates can sometimes be controlled if the electrical system is not letting the signals go in as rapidly. So if your heart rates are in the 70s or 80s, you're just labeled as atrial fibrillation. But if your heart rates are fast, that's when you're called as atrial fibrillation with rapid ventricular response. Because if you remember, I said atrial fibrillation has 3 issues. It makes the heart rate go fast, makes it beat irregular, and increases the risk of stroke. So when it's going fast, that's what is atrial fibrillation with RVR. Does that make sense? All right, sounds good.
I have a question on implanting a loop in my body. Could you
Yes.
talk about that?
Yes. So there's several indications. One of them is, if somebody has had a recent stroke, they don't know a clear reason why that happened. Atrial fibrillation, as we saw, is a common trigger for strokes. So implanting a loop recorder is a long-term monitoring strategy. Some of the monitors we have on the chest that we can stick, the longest they can last is about 30 days. But these implantable loop recorders, they can last up to 2 to 3 years. So if anybody has an episode of atrial fibrillation in future, it can detect it, and then they can be started on necessary treatment. If somebody is having episodes of passing out and there is no clear reason for it, that's another reason for the loop recorder. We can diagnose it and treat it. If someone has atrial fibrillation already, we can also use it for tracking, to target therapy, to see if they're having recurrence. Those are the 3 common reasons we usually use it for. Sorry, I'm
No,
taking your question to add more. Yeah.
Most people don't feel AFib.
Yeah.
Some people are wildly symptomatic with it, where they can feel flutters, palpitations, all the stuff you said, fatigue. A lot of people walk in, they have no idea they're in it, and they could be in the RVR or something fast, and they just pick up, or they unfortunately come in with a stroke, and we say, did you know you're in AFib? And they didn't know that. So most people don't feel it, but if somebody has a stroke, we don't know why they had one. That's one of the most common reasons they put those implantable loop recorders, is to look for AFib, because it could, like you said, come and go in the paroxysmal nature, where you may have it for a little period of time, not have it, have a stroke, and you come in normal rhythm. We want to see if there's AFib in the future, and that's a long-term way to monitor that.
My question is regarding the pharmaceuticals that are available once you're in AFib. The Apixaban,
Apixaban? Yes.
which is the Eliquis.
Eliquis, yes.
And then the other one is
Rivaroxaban.
Rivaroxaban, yes.
So why are they so expensive? They're over $600 a month.
That's the...
And they're available in Canada for much less, and they already have the generic version, which the FDA has not approved for the United States yet. Do you ever get questioned regarding or send in to the FDA that you're using this much more often? And people really can't afford that, nor should they have to pay that for a medication.
Yeah, this is unfortunate, and we always, we understand the struggles of the patients as well. We try to see if they meet sometimes, patient assistance, sometimes through the company as well. But unfortunately, we don't have control on this. This is the way the FDA and the regulation, because they have to make sure that the medications are safe, and the process goes through a lot of careful auditing. And the research involved, the manufacturers get to dictate the price. And unfortunately, we don't have a lot of say on it. But the hope is that, these medications are going generic soon. And that's what we are looking for. I understand your frustration, and I hope for it, and I look forward to it when it goes generic. I don't know if you have any inputs.
Some of it
on-
involves the patent. They developed the drug, and this was a very novel, new medication. Before we had but one medication, that was warfarin. And then they were having these problems with it going up and down, the thinness or the thickness of the blood, and they came up with this new medication where you're always in the right thickness, never too thick, never too thin, don't have to watch your medications that you take. You don't have to watch your diet as closely. There's a lot of benefits to this medicine, but this was a novel, new way to reduce the risk of stroke. So they developed this. There's a patent tied to that, and then they get to use that for a period of time before it's released into the generic, which again is way out of our control. And believe me, when they bring us samples, which are like gold, it's they ask, do you have any questions? And my single question every time is, when are you going generic? And or do you have more? And they stopped asking me now. They just say, I brought you samples, and I say, please come back, or I have 2 more people that would like them. So we get it, and it's truck. I don't have a lot of experience with the Canadian aspects. I mean, I'll usually
consider, it's because the risk benefit doesn't really line up for them.
Okay, well, let this be our last question tonight. So, lucky lady.
Thank you. Pardon me, it has 2 parts. If you've already had an ablation, does that prevent you from being able to have a Watchman-type procedure?
No, they are for different reasons. So think of the ablation as the electrical system of the heart. We're trying to fix the atrial fibrillation and to reduce the risk of it coming back. Whereas with a Watchman device, we're reducing the risk of stroke. We're sealing up that pouch which has the highest risk of forming the blood clot. So they're completely different procedures in what we are trying to achieve. Although the approach, in terms of putting a catheter through the groin or being under anesthesia, they are similar. What the technique and what we're trying to achieve is completely different.
And I tell most people, treating the AFib for symptoms is one thing, and he could burn and freeze and do everything and keep you in normal rhythm, but it still doesn't reduce your risk of stroke long term, because AFib could come back at any point. And like I said, most people don't feel it, and sometimes even after the ablations, they don't feel it the way they did before. They can sometimes have less symptoms and less frequency of it, which is the real goal in doing the procedure, but it still is a separate discussion between the blood thinner is there for stroke risk, whether you're in or out of AFib. Once you've seen AFib, the risk of stroke is technically there, because it could show up some random Tuesday night, months from now, years from now, and not know about it, especially if you don't feel it. There'd be the risk, which is why they recommend blood thinners, or in some situations they have that monitor to watch for more episodes of AFib.
And the KardioMobile or Apple Watch, for those of us who already have a pacemaker,
You don't need those.
Nope, you've got the ultimate device.
You don't need
It's
it.
inside your heart. Yep, we're trying to look at stuff outside, and that is wired inside your heart. That is the ultimate answer, and that's arguably one of our favorites, my favorite, because they come in and say, I think I had this. Nope, that is there, or yep, you sure did, because you can't miss it. It's right there. And then we check that on a regular basis, every 3 months they're watching that to pick up anything. And sometimes that's how we find AFib in people that have a pacemaker. In the checks, we say, hey, we picked this up to talk to them about reduction in stroke.
Welcome.
Well, thank you, everybody, for coming out.